The two treatments, RNA editing and AAV viral delivery, can be received without concern for one or the other. In fact, similar approaches are being used for spinal muscle atrophy. The treatment separation could in fact be years apart without any consequence. Yeah, following use of an AAV gene therapy, such as with neurogene or Tatia, a patient is prevented from receiving a second treatment. It is because of excessive immune sensitivity caused by AAV and toxicity to the patient. The patient could receive a second treatment if not delivered by AAV, by a lipid nanoparticle or another small RNA-mediated mode of delivery. Yeah, it's really difficult to forecast results from first-in-human trials. The decision around risk-benefit versus disease is really pretty variable and very personal. So it's easy to see the logic of gene correction by base editing, where the gene remains under its normal genetic control, as opposed to the AAV gene replacement therapies. However, both approaches could pass the clinical threshold for benefit. So if time is a factor, then an immediate treatment trumps, waiting for the best corrective treatment. If families see risk in gene therapy or gene correction by mutation or gene misregulation, or risk from the viral delivery platform, then the RNA editing approach would be more valued. So it's really a very complex matter to put on the table. Thanks. Yeah, distinct mutations have differing effects, and those differing effects impact disease severity. So MECP2 protein has many binding targets, and so it therefore regulates many pathways. A mutation affecting one pathway linked to one distinctive mutation may not affect the other, and so the disease will show different symptoms, some of which are more severe than others. Yeah, most definitely. Gene replacement therapy, RNA transplicing, DNA integration are all capable of large gene segment replacement and therefore would encompass treatment of any mutant allele. Yeah, children and adults can benefit from treatment, and in fact, both are part of the Tatia neurogene clinical trials. R271 is a severe mutation, which is why many new approaches like RNA editing are selecting it as a clinical target. So knock on wood for some progress there. Yeah, currently, AI is effective in designing and making the therapeutic. Automated RNA synthesis in a large design space enables scaled screening and iterative design feedback loops. AI is also strongly utilized in bioinformatics and computational predictions of on and off targets, the toxicity measures of a gene correcting therapeutic. So the use of AI can also have high impact on creating a disease model, which can link surrogate biomarkers to clinical outcome and accelerate the clinical development process. Yeah, a good estimate could be made from the timelines projected by Tatia and Neurogene for the AAV gene replacement therapies, where these are set up as a phase 1/2 safety study, which proceeds into a single phase 2 registrational study. With each phase estimated for about a year and a half, a 3 to 4 year time frame is the earliest but valid target for approval and access. Thanks.